this morning we have our opening plenary session, and in keeping with our theme of improving the care of coronary surgical patients globally, we're going to begin this meeting with a lecture from a cardiologist who needs no introduction. His name is Patrick Serruys, arguably the best-known European cardiologist still living today, and he's a dear friend and a colleague whom I respect immensely, someone who has been innovating and advancing the field in interventional and non-interventional cardiology, and now reimagined himself as an imaging specialist as new technologies bring new forms of coronary imaging to everyday practice. And he's going to give us the opening keynote address of this 10th Annual International Coronary Congress, How Revolutionary Pharmaceuticals Will Change the Future of Coronary Care. Dr. Serruys.
So, good morning. That's the title selected by David Taggart and John. It's not my title, it's their title. And you see it's an interventional cardiologist talking to the surgeon about pharma. So at any time you can leave the room or look at your iPhone and see what you have as a message, because it will be heavy, I can tell you. I think that, yeah. So what is going to impact revascularization in the next 16 years? Because I had to do that talk at the ESC, and I can tell you it is omic, genomic, lipodemic, proteomic. Polygenic clustering and AI will help to detect CAD, to predict prognosis, and to personalize treatment. And combined with non-invasive imaging, you will have what we call with Gene Braunwald imagenomics, which help to document CAD anatomically and functionally, and to allow decision-making between pharmacological revascularization. That's the new term, like we have seen in the EVAPORATE trial, and I come back on that, between pharmacological revascularization and mechanical revascularization, PCI or CABG. Now, biological and gene editing will boost the pharmacological revascularization with all kinds of things, and I will go through all these listing there, the microRNA again, LPA, PCSK9, monoclonal antibody, etc., etc. But the rate of mechanical revascularization may diminish, at least in the young patient. So let's start by SNP. SNP is a single nucleotide polymorphism. It is the genomic of the poor man. The substitution of a single nucleotide at a specific position in the genome generates variant allele with as consequent loss of gain of function. You will understand that. And we see on the left-hand side some identification of allele associated with CAD, and among them we could recognize PCSK9, lipoprotein lipase, and ApoB. That's already identified 10 years ago, more than 10 years ago, 14 years ago. So loss of gain of function offer the option of Mendelian randomization with long-term follow-up between the individual who have that allele and those who doesn't have, and allowed to understand the function of a gene and pave the way to novel biological treatment, for instance, PCSK9. Now, from 2006 to 2024, 260 locus of gene have been identified. Inactivating mutation is a pathway to novel therapeutic agent. Here we see various physiological pathways related to genetic locus associated with CAD. You see LDL cholesterol, lipoprotein as indeed associated with the locus of gene for PCSK9, ApoB, LDL receptor. Triglyceride with lipoprotein associated with locus for lipoprotein lipase, inflammation associated with interleukin-6, and so on. That's enough for the moment. Now, the three phases of the pathophysiology of atherosclerosis, the first phase is accumulation of lipids in the intima of the vessel, and anti-lipemic therapy contribute to the reduction or cessation of this stimulus. The phase 2, after oxidation and the phagocytosis of lipids by macrophage, an intense inflammatory cascade occurs with recruitment of more inflammatory cells and release of cytokines culminating in tissue damage, necessitating the use of anti-inflammatory therapy. And then the first three, when the plaque ruptures, antithrombotic therapy must be used to minimize the consequence of thrombus formation. Now, the Braunwald hypothesis is based on cholesterol years and suggests that a lifelong low LDL, either by genetic, excellent lifestyle, or institution of LDL-lowering therapy at the early stage will avoid the CAD therapy. And conversely, with a severe hypercholesterolemia from birth, in familial hypercholesterolemia, for instance, will be responsible for CAD at a very young age. Now, this slide shows the relationship between density in gram per ml versus diameter in nanometer. Kilomicron at the top, very light density lipoprotein, intermediate density lipoprotein, light density lipoprotein, LPA, LDL, and HDL. And you have to note that LDL and LPA are very similar in terms of density and diameter. And the important point is that only lipoprotein with diameter below 40 nanometer can go into the subintima. That's the key point. Now, here we see the transformation of these lipoprotein in vivo. Fat is absorbed by the small gut and enters the bloodstream as chylomicron. And these chylomicron is hydrolyzed by endothelial and hepatic lipase to provide free fatty acid that we use in our muscle and we use deposit in fat stores. And then you have the kilomicron remnant particle who can enter the vessel wall because they are small enough. The lipoproteinase has an additional role in hydrolyzing very low density lipoprotein, VLDL. That's particles secreted by the liver to produce intermediate density lipoprotein, IDL, subsequently degrade into low density lipoprotein particle by hepatic lipase. Both kilomicron remnant and LDL can penetrate the vessel wall and propagate the atherosclerotic plaque. So you know enough, okay? Now, cardiovascular surgeon and interventional cardiologists should work in symbiosis with optimal medical therapy, OMT. If they don't do that, the OMT will take over their business, okay? So the evolution of lipid-lowering therapy went from combination of statin, ezetimibe, icosapent ethyl, benzoic acid, and fibrate give daily, okay? The next step is to go to the monoclonal antibody against PCSK9. That's alirocumab, evolocumab, evinocumab, sorry for all these names, give monthly or bi-monthly. Then you have the antisense oligonucleotide like pelacarsen, you will hear about that because that's Novartis, give weekly or monthly. Then you go to silencing microRNA, inclisiran or olpasiran, B annually, 2 times a year. Then you go to the vaccination, which is in phase 1 for atherosclerosis, and then you go to gene editing for life. One single treatment, and that's it for the rest of your life. And it's in phase 1. They are patient. So if you see the Verve company, that's my friend Sek Katiseran, is working on 2 gene editing, angiopoietin and PCSK9, and you will see some of the result. And then you have to realize that we have to work on the inflammatory part of the disease, and that's colchicine, interleukin-6, and then I would say a few words about inflammasome. You will hear that repeatedly. Now, at some point in time, lipidic abnormalities will be under control. On top of statin, ezetimibe, benzoic acid, there are new anti-lipidic in our armamentarium against LDL, LPA, triglyceride, and HDL. That's what you're asking me. So the listing is there. You have PCSK9 monoclonal antibody, Praluent, Repatha. That's commercially available. You can use it. Then you have mimetic peptide. I'll say a word about phase 2. When you see 2 stars, it's because it's phase 2. Then you have silencing microRNA, commercially available. That's inclisiran, Leqvio. You have also some other which are in phase 2. Then you have adnectin, phase 3. You have vaccination, phase 1. And you have gene editing, phase 1. And you see at the bottom then, angiopoietin, commercially available, ApoB, treatment, mipomersen, commercially available, and MMTP, I'll come back on that, lumitapide, commercially available. That's a lot of things. Now, one word about the benzoic acid. That's something interesting because it's blocking the generation of cholesterol upstream to the statin, very important. And you could see that with this kind of medication, you get a risk reduction of 15%. Then you have these alirocumab, evolocumab, inclisiran against the PCSK9, reduction of risk 15% with Praluent and Repatha, with Leqvio 25% reduction of the MACE. And then it's clear, you can look at this cartoon and you can have the slide. I mean, if you call me, I'll send an email, I'll send the slide to you. It's education. I mean, everybody should have this slide, yeah? But just one word about what the European Union and the United States has said. For patients who do not achieve their goal on a maximum tolerated dose of statin and ezetimibe, you can go to PCSK9. It's a little bit more conservative in the United States, but that's okay. Now, if you don't like the injection that you have to do to yourself, subcutaneous, you could go to these new things, which is the oral PCSK9 inhibitors. That's one who has a number, and you could see is as good as the subcutaneous injection of evolocumab. So you will reduce your LDL cholesterol by 60%. And there is another one, even more, it's an oral macrocyclic peptide. And you could see it's a very small molecule, but you will reduce your cholesterol to less than 50 milligrams per deciliter. This is the things I'm really amazed. And I know Sek very well. This is the gene editing, using messenger RNA for changing adenine in guanine in the vocabulary of the DNA RNA. So the mechanism of action is you deliver by a single intravenous infusion into blood of lipid nanoparticle taken up from the blood by hepatocyte through the LDL receptor. That's the statin. Then that drug is localizing the base which is editing the PCSK9. And then there is a single spelling change from adenine to guanine. One adenine to guanine. And then that's it. Your cholesterol go down to less than 50 milligrams for the rest of your life, one time. So imagine that we have that in young patients when you have the omics to say that's the guy which is going to be in trouble. I think interventional cardiologists and surgeons will be out of business at that moment. But okay, let's go on. So this is reality. You see what they have achieved in the monkey, one single intravenous injection, and your cholesterol is low. And it has been done in 13 patients. And you could see that with the highest dose, you go around 40%, 60% of reduction of LDL cholesterol. So gene editing, if there are young people in the room, that will be the future. That's what you have to study. Now, one small word about LPA. LPA is something that is very similar to LDL, but there is something in that molecule which is amazing, is a part of plasminogen there. I'll explain that. But you could see that in terms of nanomer and density is very similar. Do we have drug to correct LPA? Yes, we have. We have olpasiran, phase 3. You have, sorry for the name, zelaciran, phase 2. And you have another one, phase 3. You have a few antisense oligonucleotide, pelacarsen. That's Novartis. Novartis is a company of $58 billion. So they will do something with that molecule, believe me. Okay, and then you have a small molecule and inhibitors LPA. Now, what is LPA? That's another bad guy. Why? Because as you could see, it's ApoB, that's a protein. You have the lipid, the LDL cholesterol, and the triglyceride. And then you see, I put the pictures of crinkle. You know what is a crinkle? And there is a chain of crinkle. That's ApoA, different length. But that explains why this molecule is pro-thrombotic. So the LPA is not only pro-atherogenic, pro-inflammatory, pro-calcific, and pro-thrombotic. It's really a bad guy. And what is amazing is that genetically determined. You can do whatever you want with your nutrition of exercise. It will not be influenced. It's genetic. 20% of the people in the world have that gene. That's literally a billion of people. And LPA is an established risk factor that increases the risk of atherosclerotic cardiovascular disease, coronary artery disease, aortic valve stenosis, and stroke independently from the conventional risk factors. And MACE is correlated with increasing LPA concentration. We have 3 medications against LPA. First, we have silencing microRNA, which is going to induce some reduction of that. There is 3 compounds. The most advanced is zelaciran. There's a trial called Alpacar, which is published in JAMA in November, so I'm quite update in that talk. Then you have an antisense nucleotide, and you have the pelacarsen of Novartis, I told you about that. And then you have small molecule which inhibit LPA synthesis by an inhibition of the formation of the disulfide bond between ApoA and LPA. And then there is also, the name of that molecule is muvalaplin. There is a trial carcan also published in JAMA last month. So pay attention, it's coming. The next tidal wave of tsunami is coming. Two slides to show what happens with the zerlasiran. As you could see, it's well tolerated, it was published in JAMA, and reduced the LPA concentration by more than 80% during 36 weeks of treatment with patients with coronary artery disease. And the other one is oral, is muvalaplin, and also reduced the lipoprotein by 86%. Now, one word about the triglyceride. You have two drugs, icosapent ethyl, commercially available, and then what we call MTTP, which is treated by lumitopide, also available. What happens is that the lumitopide blocks the combination of triglyceride and ester cholesterol, and in the gut, in the intestinal tract, you have a recombination of phosphorylation, and it goes in the lymphatic vessel. So that's pretty good in general. There is a trial, reduced IT trial, where you have a randomization between EPA and placebo, and you could see a reduction of 25% in the MACE, which is cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, and coronary revascularization for unstable angina. And we have the first trial made with multi-slide CT scan that's evaporate using this medication, again, triglyceride, and you could see in blue the type of reduction that we see on multi-slide CT scan, minus 17% in low attenuation, minus 34% in fibrofatty things, and 20% in fibrous tissue. And you could see this multi-slide CT scan where the right coronary artery is in red, and 18 months later, it is in green and yellow. So the FFR-CT went up from 0.67 to 0.79. And we are doing a big trial on inclisiran with that hope that you could modify. That's what I call pharmacological revascularization, okay? Now, I think the term will stay for some times. Now, HDL, that's a molecule I don't understand, neither the expert, by the way. Is there a soft spot for that molecule? I don't know. The only thing I can tell you that if it is low, it's not good, you die, and if it's too high, you die also. So the soft spot must be somewhere, but it's too complicated for me, so I'll skip that. I have to tell you that the Dutch company from a good friend of mine, John Kastelein, has developed a new CATP inhibitor. CATP is for cholesterol ester transfer protein. There has been a long story of failure with this kind of molecule affecting the HDL. But this time, it seems that that molecule, obicetrapib, by a Dutch, do something good on the HDL, okay? Because the hepatic receptors is increasing, the transfer of the cholesterol ester from HDL to LDL is impaired, there is an increasing hepatic LDL receptor expression, and there is an increasing catabolic rate. And here you could see that data which are not published that I got from John. There is in their work very profound decrease in LDL-C, in non-LDL-C, in ApoB, and in the LPA. So 4 of them are influenced. This is a monoclonal antibody that has been tested in the Legacy trial, increased the LDL cholesterol by 51%, but I don't know if it's good or bad, but increased the cholesterol efflux by the kidney. I didn't know that you could lose your cholesterol
via your kidney.
Yeah, that's what you said. I said something else, but so I go now to shift gear in something else, and that's the great debate between cholesterol and inflammation. You know, it has been there for 1 century, but I want to draw your attention, and I see some women in the audience. The Women Health Study report the 30 years cardiovascular outcome among initially healthy women. And as you could see, a single measure of CRP, LDL, and LPA was predictive of incident cardiovascular event during a 30 years period. When the first quintile is compared with the last quintile in CRP, the hazard ratio was 1.7. For the LDL, it was 1.36. For the LPA, was 1.33. Think about if you have all 3, okay? So the primary endpoint was myocardial infarction, coronary revascularization, stroke, 30 years of follow-up. John. Few words on anti-inflammatory, and I'm finishing on that. You have colchicine, which is ESC guideline 2A. You have benzoic acid. You have monoclonal antibody, again, interleukin-1 beta, monoclonal antibody, again, interleukin-6, and 1 word about inflammasome, if you have never heard the word inflammasome. So it's interesting because this meta-analysis on colchicine show a reduction of 33% in event. But I have to tell you that recently, the Lodoco was the good study confirming that colchicine helped in CCS. But I have to tell you that recently, this year, there was 2 trials, clear trial. Colchicine does not help in STEMI. We all believe that it was an inflammatory problem. It doesn't help. And it doesn't help in acute heart failure. You see the first curve is the BNP, non-affected, but well, a reduction of interleukin and CRP. The benzoic acid, which is available, and I'll give you some practical advice at the very end of the talk, that's something which is reducing the CRP with or without statin by about 40%. So it's a pretty good drug. And this is the famous trial CANTOS by Paul Richter in Harvard. He was the person who said there is an inflammatory component. So he used this molecule, canakinumab, and get some reduction in MACE. Canakinumab is an orphan drug. It's used as a good treatment for juvenile arthritis. You can get it, but it's very expensive. Then you have the ziltivekimab. That's a rescue trial. It's amazing. You can basically eliminate the interleukin-6 from your blood. You can see the graphic. And then 1 word about the inflammasome. Cardiologists are very excited about that. It's a macromolecule complex that is triggered by injury, so maybe by bypass surgery you should look at these things, and amplify the inflammatory response. The core of this macromolecule is the caspase enzyme that activates the pro-interleukin 18 the pro-interleukin-1 beta, 2 precursor of interleukin-6. And that contributes to the oxidation of the LDL and triglyceride, phagocyted by the macrophage, that degenerate in foam cell and necrotic core. And multiple drug and monoclonal antibody, which is listed on the slide, are currently tested in the inhibition of the inflammatory itself and its byproduct, interleukin-6 and 1 beta. 2 slides about being practical. What the cardiovascular surgeon should measure and treat in their patient after surgery. You can take a picture because it took me a long time to make that slide. But so you have the LDL cholesterol. If your LDL cholesterol is above 55 milligram, you have a huge option of treatment. You can use ezetimibe, and I'll give the name, the commercial name, Zetia and Ezetrol. If I ask in the audience who has been using Zetia and Ezetrol, I don't think that there will be one single arm. No. Then you have the benbepoic acid, that is the next lethal, commercially available. You have the anti-PCSK9, Praluent Repata, you know about that. You have the small interfering RNA, inclisiran, commercially available, like Leqvio. You have the anti-angiopeptide monoclonal antibody evinacumab, available with a name which is terrible, Esqueza. You have the antisense oligonucleotide, Miposen, Kinamro, and you have lomitopide, Lojuxta, commercially available. You can prescribe these things, okay, if the cholesterol is above 55. And you remember one while, if your whole life you are below 55, you will not get the coronary artery disease. HDL cholesterol, not yet phase 3, so you can forget about for the time being. Lipoprotein above 50 milligram, LPA. I mentioned a few times pelacarsen, phase 2 and 3 with Novartis, but there are other in the pipeline. Triglyceride, you can treat. Above 150 milligram per deciliter, you have the Lojuxta and the Vascepa. And then at the end, if you believe in the inflammatory aspect, you can prescribe colchicine, which has some side effect like diarrhea, but benbepoic acid is very well tolerated. So this is the last slide, which is the pragmatic guideline on use of secondary prevention. We have to make the difference between lipidic and inflammatory residual risk. For the lipid residual risk arm, we have to check for additional risk factor such as LPA, 20% of the worldwide population, and you have to check for triglyceride. If the LDL is still above 55 milligram, you may add ezetimibe. If the LDL is still not achieved, you can use benbepoic acid or the inhibitor of PCSK9. And for the inflammatory residual risk, we have to measure the CRP, add eventually colchicine. If you are wealthy, you can use the canakinumab, the drug for the juvenile arthritis, an orphan drug, and potentially check the interleukin-6, and if it's more than 1.6 nanogram per liter, switch to ziltivekimab, which eliminates the interleukin-6 from blood. That's it. Now, if you don't take care of the secondary prevention with at least statin, what is going to happen over the next 10 years following your surgical intervention, that the pharma will take over. So this is the ultimate legacy of the syntax study. I could not believe we followed this patient after surgery and PCI for 10 years. It was 2003, published in 2009. You look at that, it's almost a randomization. They are the patient who never used statin. Mortality, all-cause mortality, 39.1%. Okay? When you have a statin, 22.2%. So really, we have to do something. And you know, the interventional cardiologists are not better. We are running a lot of trials. It's amazing what you see. 85% does not achieve this 55 milligram. 27% have hemoglobin A1C, so that means diabetes not recognized or poorly treated. LPA, I don't mention, it's catastrophic. So really, if we don't go in that direction, and we will have to watch, you have to watch the gene editing, because that's really can change your life. You know, at the ESC, I had to talk about revascularization in 2040. The year before, I had to talk about coronary artery disease in 2033. So next year, I don't know what they're going to ask me. But it's going to change. I mean, AI, this kind of drug, and the COVID had a very positive aspect of that, because it's all silencing microRNA. If you have had this vaccination with, for the COVID, it's silencing microRNA. So, as usual, bad things bring good things, but it will change. So this is my last slide, and as you could see, a copy of all the slides can be requested. Okay, so I know that you are interested. That will be my personal survey, and that's it.
Patrick, thank you for a brilliant presentation. I think that all in attendance understand why this year we opened our meeting on surgical revascularization with this brilliant keynote address from, I think, the individual who's thinking most deeply about the disease we are treating surgically. So thank you so very much.
There is a question from the floor, please.
Yeah, we have questions.
Yeah, well, we're going to do that at the end with a Q&A. Thank you.
Fantastic. So from pharmacological revascularization to revascularization with interventions, it's a pleasure to host today Dr. Thorst Dunst that will speak about CABG and PCI benefit patients by different mechanisms. Professor.
Chairman, ladies and gentlemen, thanks up front for the invitation and the ability to talk. And the situation right now here that reminds me a little bit of a story that a good friend of mine once told when he started a presentation, and he said that in the morning the teacher in school asks the class, young students, and he says, so where's God? And so the first guy raises his hand and says, God is in heaven. He says, yes. So he says, the second guy raises his arm and he says, God is in my heart. Jesus Christ is in my heart. And they said, oh, this is so nice, you know. So a third guy is raising his arm. And everybody's like, okay, so what do you think is Jesus Christ? What do you think is God? And he says, well, Jesus Christ is in our bathroom. And the doctor and the teacher says, Jesus Christ is in your bathroom. How does that work? He's like, yeah, well, in the morning when we're all trying to get ready, and my sister, my older sister, is in there forever. And, you know, my father, he knocks against the door, and he always screams, Jesus Christ, are you still in there? So, you know, this is the situation. Jesus Christ, Patrick, what an opening for a coronary surgery session. You know, it's unbelievable. So with that, you know, I'm having the difficulties in getting into the grind of things here, and which is very difficult, and talking about the basic things. I mean, maybe one thing is that currently we treat mostly secondary prevention, and you mentioned that at the end. Because all of the stuff that you mentioned is happening if we start treating patients who are not patients yet. It's primary prevention. That's where the big argument is, and I think it'll take at least enough time that all of us here, in our sort of surgical careers will be able to end it without seeing the major impact that you have described as the future perspective. And I truly, firmly believe in it. All right, so with that, I would like to go into my presentation and see I have no conflicts. So what is the revascularization paradigm? We've heard modifications of the word. We believe that revascularization, whatever you envision about this, most of the time we combine PCI and CABG, and you've termed it mechanical revascularization. We believe it treats ischemic symptoms, angina. We believe it improves contractile function. If it is impaired, it prevents myocardial infarction and survival, right? That's the idea. And I would like to have some hands raised if anybody disagrees with that. All right, so no one disagrees. So what happens is you have you have your coronary artery, and then you have your flow, and then you have plaques forming, and once the plaques are forming here, then sometimes that gets stenosed, then you get symptoms, and at one point in time it occludes, and then you get your myocardial infarction. But there's another mechanism for myocardial infarction that actually is much more relevant, and that is that you have a plaque that suddenly ruptures. It's completely harmless before in terms of flow limitations, and then the thrombus that's forming is causing the situation. And if you look at the left side, these are the origins of vessels causing infarctions, and so the vast majority of infarctions are stemming from lesions that are not flow relevant. Okay, so that's something, please keep that in mind. And that's why we need to look at the different mechanisms that we exploit when we apply mechanical revascularization. So let's say we have inducible ischemia, okay? You have coronary artery disease, you have inducible ischemia. But inducible ischemia, there's no ischemia at rest. So if somebody tells you the stress test showed 20% ischemia, that means it is 20% ischemic if there is exertion, if there is exercise, not at rest. If I had 20% ischemic heart disease with triple vessel disease, I would not have ischemia right now. So you get the ischemia upon exercise. You have to, the mechanism for that is, what do you do if you put a bypass or a stent? You increase coronary flow capability because you have to have more flow. You are able to have more flow once it is needed, but you don't need it right now. Then, of course, you have acute ischemia, ongoing ischemia, whether it is acute here, classic acute coronary syndrome, or whether you have chronic ischemia, whether that exists. We'll get to that in a second. And then there is obviously something else. That's the risk of infarction. I just showed you the mechanism, the main mechanism. It's a risk. And we may all have here some coronary disease, and we may not notice it. We may not know it because nobody has the imaging yet. And that's why the problem, the risk is there, and we may not even realize it. But it's not going to show it. We don't treat that, at least not alone. So let's go in and see what the different trials tell us about the different mechanisms. So if there is inducible ischemia, and we can test that with stress tests. And ischemia, the trial, has been the ideal test for that, because it tested if there is presence of ischemia, then there was mechanical revascularization, right? And they even combined PCI and CABG, and then see, okay, so the mechanism. So you all know the trial. What did it show? You have less symptoms. Freedom from angina was better. Not completely eliminated, but it was better. But no difference in survival. No difference in survival. So you have, we restore coronary flow capability, you have symptomatic relief. No difference in survival. So what about reperfusion as a mechanism? So you have reperfusion that, if there is no reperfusion, then of course cells will die, myocardium will die, you have your infarction. You lose contractile function, you die. So maybe that's where the survival impact comes, and then you have to have reduced ejection fraction. The Stitch trial did that. So what did the Stitch trial show? Yes, there was a survival impact 1.5 years longer life in 10 years. So a significant reduction in mortality after 10 years with CABG compared to medical therapy. But there's a problem, because if you have the subgroup received viability testing and stress tests, and so there was, without viability, there should be no impact of CABG. But the signal in the direction for better survival was still there. There's a problem. How do you explain that? Well, we don't have to worry about more than that, because there's the REVIVED trial. The REVIVED trial did basically the same thing as STITCH, minor discussions, you can argue on details, but it tested in patients where there was proven ischemia, inducible ischemia, whether the relief of this flow-limiting lesion actually improved survival, death, hospitalization, whatever. What's the outcome? Nothing. The stent, there was only stent, showed nothing, no difference in survival, not even in heart failure hospitalizations. Okay? So the invasive treatment, the mechanical revascularization in this case, didn't do anything. So the reperfusion mechanism, the chronic ischemia mechanism, at least if we treat mechanically with, invasively with PCI or with CABG even in this aspect, it didn't help. So what does it leave in terms of mechanism to explain what we found with STITCH? It's the risk of infarction, maybe. Now, STITCH didn't assess infarctions in the follow-up systematically, so it's very difficult to tell. But there are other trials that assessed and monitored infarctions as well. And those are summarized in the HEAD meta-analysis, and you all know this publication, where there was a 2% reduction in mortality, a significant reduction in mortality with with CABG compared to PCI. So again, a survival advantage of CABG compared to something else, medical therapy, PCI. And if you then do this, you subtract the infarction rates that you find in addition to whatever mortality or so, non-fatal myocardial infarctions. If you subtract them from CABG from the PCI group, then you find the fewer infarctions are happening in the surgical group, the better the survival. So there's a correlation between the infarction rates that you detect and your mortality rate. And I mean, that's clear, because if you prevent 10 myocardial infarctions, you probably prevent 1 or 2 deaths, because the mortality from myocardial infarctions, even today, is still about 10%, 20% maybe, depending on where you are and what you look. So this led us to this concept where if you treat a significant lesion here with the bypass graft, you're also bypassing all the other lesions. And if there is something happening later on, or if there's something developing later on, then you treat this with this graft. So you collateralize, because a collateral prevents an infarct if there is a vessel occlusion. You all know this, the right, so I don't have to explain this to you. So this is a surgical collateral on top of something where we revascularize something. Now, if you put a stent into a flow-limiting lesion, and later on something happens further down the line, it cannot treat this. And if you remember, 90% of the infarctions arise from non-flow-limiting lesions, so how can a stent reduce myocardial infarctions? And Mario actually did this, and we did this together, but Mario did a perfect job in analyzing this, and we looked at all the studies, randomized, non-randomized, that compared CABG and PCI, and did this meta-analysis, and there was this again, CABG is better than PCI. But CABG was only better if there was a difference in the groups in spontaneous myocardial infarctions. Less myocardial infarctions, better survival. End of story. It's always the same. And if there's no significant difference, there's no difference in survival. Of course, grafts have to stay patent. Okay, so the bottom line here is, if you treat inducible ischemia, you have symptomatic relief. Yes, even Orbiter showed this. If you have risk of infarction, you improve survival if you prevent future infarctions. And prevention of future infarctions in the current setting can be best done by surgery with the collateral, surgical collateral. Not all infarctions are lethal. You may have situations like in the NOBLE trial, no difference in mortality, but significant difference in myocardial infarction rates. Same with the left main issue, because here there is mortality. There's no left main trial of PCI versus medical therapy. So you compare PCI to CABG, find no difference in mortality, but there's a difference in myocardial infarction. Again, CABG has greater potential to prevent from infarction. I could go on forever. If the patient, the sicker the patient, the higher the risk of myocardial infarction, the greater the treatment potential of CABG. So let's get back to that left main issue, because then there are registry studies, and they suggest that CABG and PCI is better than medical therapy. And of course, I mean, if you imagine if PCI dilates a shaft lesion and the left main occludes, if that's sort of the consequence, then of course a left main occlusion is death. That's an infarction that you don't really survive at a high likelihood. So the chance that a stent in the left main actually prolongs life is pretty good, right? So how does that work? So there's old meta-analysis from Windecker in 2014, network, we know everybody against everybody. So he suggested at the time that the stent is able to prolong life, and he did this by these all-cause mortality rate ratios here. But he also gave rate ratios for myocardial infarctions. And if you plot them, this is the big picture you already know, CABG versus PCI. Less infarctions with CABG, better survival. This is the rate ratios of Windecker, correlated, risk of infarction, risk of death. Again, a straight correlation. So even with PCI, where the potential to prevent infarctions is lower, any signal on survival improvement is related to prevention of myocardial infarctions. And if you look at contractile function, to come to the next point, there's evidence that after surgery function improves, right? That's a registry analysis here, single center. But if you look at the trials, there's no difference. There's no difference in contractile function. You do not improve contractile function with revascularization. Why should you? Because I don't have ischemia right now. The registry trials probably have not optimal medical therapy. They need to optimize that after surgery, and that's something that's all controlled for in the trials. And they also may have acute ischemia in there as well, which of course then makes a difference. So the revascularization pattern, it treats ischemia, it treats ischemic symptoms if we do something mechanically, yes. I think that's clear. It improves contractile function if it's impaired. No, unless there is some other culprit sort of that, or other buddy that we have, like medical therapy, that helps us improve function in heart failure, or you have acute ischemia ongoing somewhere. That's also an issue, but that has not been in the trials. So it prevents myocardial infarction. CABG has the greatest potential, and improves survival. And again, CABG has the greatest potential, and the limit, and PCI is very much limited there. So this is the new idea, then. This is not a new idea, but this is something you have to think about. So you have a patient that has non-obstructive disease. Unless we image them, and not by stress tests, but unless we show the coronaries that have this, and Patrick's fast-track CABG and efforts on imaging the coronary arteries with CT go exactly along those lines. So do you have this coronary disease here? Some of them go to obstructive disease. Those are the ones causing symptoms, and then you are going to the doctor, and then you get treated. And if you progress, you may get an infarction, but the infarction here is only a minor fraction of all infarctions that are actually happening. So those are the lucky ones, because they have their symptoms, they get it detected, we can treat them. We can treat them as surgeons, but the majority of patients have this mechanism. They get plaque rupture at one point in time, suddenly, out of the blue, and they get their infarction. That's the vast majority of infarctions. And so the best way to treat a patient and prevent his infarctions is to put a surgical collateral. But our problem is, I'm not suggesting that everybody needs surgery now. I'm suggesting that we need to generate patients we need to look for the infarction risk. And if somebody has a lesion here, that helps us to keep a patent graft. We also have the ability to prevent from future myocardial infarctions, and that's sort of the action, and that is something that the stent alone cannot do. And with that, I would like to say, do not revascularize, but rethink and treat use a mechanism-based approach for treatment, and use surgical collateralization if the risk for myocardial infarctions is high. Thank you for your attention.
Thank you, Torsten. A great presentation, and I think this is an important concept. Just as secondary prevention is critical to the maintenance of good outcomes for CABG patients, the mechanism is very different compared to that of PCI. Our next speaker is Dr. Taggart. It needs no introduction, and is going to talk about, I think, really leaning on the introduction that Torsten gave, the maintaining coronary bypass as the gold standard.
Thank you, John. We have been fortunate to start with two excellent presentations. And I have to say, I was a bit dismayed listening to Dr. Soroy's, because he was describing all of these new therapies that are going to make the issue of CABG and stents irrelevant. And then I realized, however, most of these new therapies have unpronounceable names. So it means most doctors won't prescribe them. They'll stick to aspirin and statins. So we may not be put out of business as quickly as you think. So what I'm going to do in the next 10 minutes is talk about, seems to be frozen. What I'm going to do in the next 10 minutes is talk about where we are with CABG and PCI today. And I'm going to illustrate the consistent and persistent efforts in the literature to distort both clinical and scientific reality. When we look at CABG versus PCI, there are always three very important cautions when you're interpreting data. Always ask yourself, who are the patients? The patients are often highly selected, and you can predict the outcome of your trial by selecting particular patients before the first patient is randomized. The second is, if there's not a minimum duration of follow-up of 5 years, don't accept what you're being told. Remember, 80% of patients with coronary artery disease will be alive at 15 years, so we need to know what's happening way beyond 5 years. And the third thing to consider is look at what patients received optimal medical therapy, because in the majority of trials of PCI versus CABG, CABG patients receive inferior medical therapy. And the next final tip is, if you're reviewing a paper, either for yourself or for a journal, never read the text. Look at the results, look at the data, because by the time you've done that, you should then know what is in the text. But many papers describing PCI and CABG will have a very pro-PCI bias at odds with what the data actually shows. This is still the most important trial done in coronary artery disease that requires intervention. Dr. Soroy was the principal author, and this showed in the Syntax trial, and it was a very important trial because it was a relative all-comer trial compared to all the previous trials that had been very highly selected. And it showed a very clear benefit at 5 years for CABG in terms of reduced death, cardiac death, myocardial infarction, and the need for repeat revascularization. And the second thing it showed was that the benefits of CABG became magnified when there was more severe disease. So in the low Syntax scores of less than 23, there was a 1% difference in mortality at 5 years, but for the intermediate and high syntax scores, those benefits were respectively 7% and almost 10% at 5 years, accompanied by significant reductions in myocardial infarction and the need for repeat revascularization. So very similar to what Torsten Dunst has just been telling us. So one of the things, the syntax trial was then criticized heavily by the cardiology community on two bases. It first said there was no use of FFR in syntax, and that also syntax had used an old generation drug-eluting stent. So the FAME3 trial was designed to address both these limitations. It randomized 1,500 patients, either to PCI or CABG, used FFR-guided PCI, and used the best current drug-eluting stent. Now, the primary endpoint, and this is crucial to understand, at 1 year was a composite of death, myocardial infarction, stroke, and repeat revascularization. So there were 4 components to the primary endpoint. And at 1 year, you could see there was a significant benefit of CABG over PCI. So PCI did not meet the criteria for non-inferiority. But what we all wanted to know is what happened at 3 years. And this was published in Circulation in 2023. And if you actually look at the primary endpoint of the trial, it was highly in favor of CABG over PCI, with a very significant reduction in the hazard ratio. But what did the authors do? They changed the endpoint for the major publication. They now used death, MI, stroke, and removed repeat revascularization. Now, there were 40 authors in this paper. It was very widely reviewed by statisticians, other reviewers, editors. And you have to ask, was everyone asleep? In my professional career, I have never seen a randomized trial where the primary endpoint was changed halfway through the trial. Has anyone ever seen that before? So this is a deliberate attempt to a wider readership to distort the reality of what this trial showed. Dr. Sorois was also one of the key authors of this paper, along with 14 interventional cardiologists, and I can show you any number of meta-analyses showing that CABG is superior to PCI. I could show you literally 15 different meta-analyses. And those were non-diabetic patients. For diabetic patients, the most definitive study is the FREEDOM trial, 1,900 patients, showing a reduction in mortality by 6% out to 8 years with CABG compared to PCI. And these were patients with relatively low severity diabetes. They were not the most severe cohort. And the conclusions were, by the cardiologists, in patients with diabetes and multivessel disease, CABG leads to lower all-cause mortality than with PCI drug-eluting stents in long-term follow-up. We've already heard about, for patients with ischemic cardiomyopathy, the STITCH trial showed a survival advantage for CABG appearing after 5 years and accelerating out to 10 years. This is a study by Mark Ruel's group. This was a prospective study looking at almost 5,000 patients with impaired ejection fractions below 35%, matched for 30 baseline characteristics and followed out past 9 years. And you can see that as you follow these patients, a marked improvement in survival in favor of CABG, accompanied by marked reductions in MACE, myocardial infarction, repeat revascularization, and no difference in stroke. And we've already heard about this trial, the REVIVE trial, 700 patients undergoing PCI with optimal medical therapy versus optimal medical therapy alone. And this showed that at almost 4 years, absolutely no difference in the primary outcome, the secondary outcome, death, myocardial infarction, hospitalization, or repeat revascularization. So you can say conclusively there is no benefit of PCI in ischemic left ventricular dysfunction. I'm going to finish in the last few slides just again showing you how literature can be distorted. This is the Excel trial of which everyone will be well aware, the largest, most definitive trial of PCI versus CABG, but again with relatively selected patients with syntax scores below 33, which would be 1/3 of routine practice. The randomization was stopped early. Only 1,900 patients were randomized out of the proposed 2,600, and that was never explained why that happened. And it was important, these patients had a mean age of 66, so they would have an anticipated life expectancy of 15 to 20 years. And the primary outcome was a composite of death, MI, stroke, but not repeat revascularization. And the trial used a new, previously undetermined biochemical definition of myocardial infarction and not the universal definition of myocardial infarction data. Now, Oxford was the second largest recruiter to this trial worldwide because we thought this was a very important trial, both myself and my cardiology colleagues. But what did Excel show at 5 years? It showed a significant increase in the risk of death in patients undergoing PCI. And when you consider these patients had a mean age of 66 and relatively low syntax scores, this was certainly a worrying phenomenon. So PCI at 5 years showed a relative, almost 40% increase in the risk of death, non-procedural myocardial infarction, and need for repeat revascularization, and no difference in stroke. It's very interesting. The editor of the New England Journal of Medicine in the initial review of this paper said, the finding of a higher mortality rate in one group than another in a clinical trial, unless the difference is clearly trivial, should receive central emphasis in the report of the results, and we would generally consider it important to include such information in the concluding statement in the final paragraph. And I thought that was a very good review. But what actually happened when the paper was resubmitted was it concluded in patients with left main coronary artery disease of low or intermediate anatomical complexity, there was no significant difference between PCI and CABG with respect to the rate of the composite outcomes of death, stroke, or myocardial infarction at 5 years. I did not believe that really reflected what the Excel trial showed. And the other thing I want to ask, where are the 10-year results? If you see a rapidly accelerating mortality at 5 years in a cohort of patients who are relatively young, where are the 10-year results? When finally the biochemical definition of myocardial infarction in Excel was explained by the universal definition of myocardial infarction rather than by the new protocol definition, you can see there was an almost 75% reduction in the incidence of myocardial infarction in the CABG group. That would have completely changed the primary outcome of the Excel trial, but this data was not presented until well after the trial was published. And the final slide I'm just going to show is how does the literature try and distort what's happening? After the publication of the Excel trial, this was a paper published in the European Heart Journal, one of the most prestigious cardiology journals. And this was exclusively done by 14 authors, none of whom were surgeons. And what this did, actually, this meta-analysis, was it effectively diluted the Excel trial, the largest, most definitive trial of left main, with 4 older, smaller, weaker studies, until the mortality benefit that was observed in the Excel trial had been diluted away. There were no indication that these were highly selected patients with left main with relatively short follow-up. But here's what I call meta-analysis magic. This study had a record speed of acceptance and publication. It was 11 days from being submitted to being reviewed, to being revised, to being resubmitted, and final acceptance in 11 days. How many of you have had a paper like that? So my advice to the audience is if you think you've got something important, submit it to the European Heart Journal and say, can it please be published in 11 days? And see what response you get. I'm definitely going to finish with this slide. So there are 3 reasons for the persisting survival benefit of CABG over PCI, despite all the technological advances there have been. Now, I've been showing this slide for almost 20 years, so there's nothing new in it. But what I have always, as Torsten explained, what is the anatomical benefit of bypass grafts? If you place a bypass graft to the mid-coronary vessel, you do 2 things. You make the complexity of the proximal culprit lesion irrelevant, and over the longer term, it offers prophylactics against future proximal culprit lesions. In contrast, PCI only treats suitable localized proximal culprit lesions, but has no prophylactic benefit against new disease. The second difference is shown by Tom Lusser 3 decades ago in the New England Journal of Medicine. If you place an internal mammary artery to the LAD, it elutes nitric oxide into the coronary circulation, and that reduces the risk of further development of disease. In contrast, a drug-eluting stent impairs re-endothelialization, causes downstream endothelial dysfunction, and creates a prothrombotic environment. And the third difference is that for many patients, PCI means incomplete revascularization, and incomplete revascularization has repeatedly been shown to correlate with a subsequent risk of increase in MACE and indeed mortality. And Dr. Sorois was one of the authors of this. So I would say that for these reasons, PCI is unlikely to ever match the results of CABG for most patients with left main and multivessel disease. It didn't with balloon angioplasty, it didn't with bare metal stents, it didn't with drug-eluting stents, and it hasn't done so with the latest concept of new drug-eluting stents. But if you understand these 3 pathophysiological mechanisms, you can understand why CABG has and is likely to remain the superior therapy for most patients with left main and multivessel disease. On that point, I'll conclude my talk. I would like to thank the organisers for the opportunity to give this presentation and you, the audience, for your attention. Thank you.
The last speaker for this morning's session does not require an introduction itself. Mario Gaudino, one of our leaders in the science behind coronary artery bypass grafting and coronary artery disease, will speak about limitation of PCI versus CABG trials. Please.
Thank you, Gianluca. Thanks to the program organizer, and thank you to the audience for being here this morning. So I think David has summarized very nicely the evidence of PCI versus CABG. So far, it has been over 2 decades since Patrick designed and published the first of many papers of syntax. So we kind of feel we know what's happened between CABG and PCI, and we have a relatively good sense of the treatment effect of the 2 interventions. My task is to show you that that is not the case. The first and most important limitation of essentially all previous PCI versus CABG trial is that they have a very low external validity. They actually apply only to a single group of patients, and this is white men. I would argue that this is, if you want to be more precise, middle-aged white men. This slide summarizes the proportion of women and non-white patients enrolled in seminal PCI versus CABG trial. You see that women generally represented between 25 and 35% of the patients enrolled in those trials, and non-white patients were in the single digit. Now, this is problematic because what does mean is that today we have no evidence of the result of PCI versus CABG in any other We do not have evidence from randomized study of the result of PCI versus CABG in any other subgroup of patients except, again, white men. And this is problematic because we do know that both PCI and CABG results are significantly different by sex and by race and ethnicity. There are important technical and biological reasons why the result of surgery are different by sex. Women tend to have a smaller and more spastic coronary artery, smaller and more spastic bypass conduits. The intervention is performed differently between the sexes. Women generally receive a significantly lower proportion of arterial graft as compared to men. There is the problem of anemia and hemodilution that is much more relevant in women, not only in terms of incidence and proportion, but also in terms of impact on outcome. So there is a lot of biological and technical reason why the result of surgery are not the same in men and women, and similarly there is a lot of technical and biological reason why the result of PCI and CABG are not the same by race and ethnicity. And those are not only reasons related to biology, but also to access to care, to socioeconomic disparity, in particular in the United States. And in fact, if we look at the evidence so far, those are two large individual patient data meta-analyses, one for PCI and the other for CABG, comparing outcome after the two revascularization modality by sex, and you can see how women have a worse outcome both early and at midterm after both intervention. And if we want to take a different angle and look at the result in white versus non-white patient after both intervention, we find exactly the same result. White patient consistently have better result, and black patient in particular have an excess risk of adverse cardiac events after both intervention. So the reality is that for the large number of patients who are not white men, and that every year are in need of coronary revascularization, we do not have data to inform a treatment decision. So what we do in clinical practice is that we use data that are generated in a different patient population to make a decision in those patient categories. But this is most likely wrong and potentially misleading. That's why we feel that the PCI versus CABG trial dedicated to those groups that have been underrepresented in previous trial is an urgent need in clinical research. And the other issue that we have with previous PCI versus CABG trial has to do with the type of primary outcome that has generally been used. Essentially, all previous trials have used some variation of MACE, a composite of cardiovascular outcome that generally included death, stroke, MI, and or repeat revascularization in different iterations. Now, as a trialist, I do like MACE. MACE is very easy, makes everything extremely simple, from power calculation to analysis. As a surgeon and a clinician, I do not like MACE. I think it doesn't make any sense, and I will try to explain why. The first and most important issue with MACE is that the individual component of this composite that are evented with largely different impact on patient are all given the same weight. So repeat revascularization of perioperative myocardial infarction affected the trial outcome in the same way than mortality. It's even worse than that because generally all trials use a time to first event analysis. And so events that happen early in the follow-up have a larger impact on the outcome compared to events that happen late in the follow-up. So if we take the example of perioperative myocardial infarction, whose clinical relevance is unclear to I think everybody in this audience, well, perioperative myocardial infarction by definition is an early event. So it will be given more weight than mortality, that is generally a late event. And again, as a physician, I think that makes zero clinical sense. The other problem is that even within each subcategory of event, there is a large variation in the clinical severity. PMI versus spontaneous MI. I mean, a bump in troponin is different than a large spontaneous MI that reduces your ejection fraction by 15 points. Let's think about stroke. There are stroke episodes that are essentially asymptomatic and you only see because you are doing brain imaging for some reason, and there are other episodes that are extremely severe and leave your patient with massive clinical consequence. Well, those events are not the same, but they are counted as the same using the classic MACE outcome. And again, this does not make clinical sense. And then why are we limiting only to the cardiovascular system? Okay, we are cardiovascular physicians, so we have a bias, but the cardiovascular system does not really represent the totality of the well-being of the patient. There are a number of non-cardiovascular events that are extremely important to patients. I would say arguably even more important than some of the events that are included in the classic MACE outcome, and they have been largely ignored by the primary outcome used by previous PCI versus CABG trial. And some of those events, when you are comparing PCI to CABG, are actually related to the intervention. Think of bleeding, think of surgical site complication. We cannot just forget all those and just ignore them. Now, one of the problems when defining the outcome of cardiovascular trial and coronary revascularization trial is that patient and physician have a very different perspective of what is important and what is not important after any medical procedure, and in this case, coronary revascularization. This is an old study from John Spertus that asked two groups of people, physician, trialist, and patient, to weight the relative relevance of different clinical events, and you see how different was the weighting and the score based on physician and patient opinion. And in general, while trialists and physicians are more focused on clinical events, even though then we struggle with the definition of those clinical events, such as in the example of myocardial infarction, patients really do care mostly about the quality of their life. That's what matters to them. And so far, we have necessarily ignored quality of life. We have relegated the quality of life, in the best case, to a secondary outcome in our previous trials. Okay. For some reason, I cannot go to the next. Okay. That's why Greg, myself, and a group of other people have generally proposed to move away I've recently proposed to move away from the classic MACE outcome that has been the gold standard for 20 years to what we consider the new gold standard, the new MACE outcome, that is a composite outcome that includes essentially only two events, mortality and quality of life. And we believe that this approach methodologically overcome all the limitations that I've described so far, and most importantly, capture what is important for patient. In a new PCI versus CABG trial that we have just launched, that is called RECHARGE, our primary composite outcome is designed to encompass all consequence of the two interventions, represent the risk and the benefit of both procedure, overcome the limitation of MACE, and reflect what matters most to the patient. And as I said, this primary outcome is essentially a composite, is a hierarchical composite, so use the win ratio, and include only all-cause mortality and generic quality of life. Quality of life is measured frequently during the follow-up, and this time averaging during the totality of the study to account for the fact that we do expect a temporal difference in quality of life between the two interventions, with clearly PCI patients having better early quality of life. And so RECHARGE has just started. A few patients have been enrolled. We'll see if this approach works. And with this, I thank you for your attention.
Thank you very much, Mario. This is a incredibly important new trial, the RECHARGE trial. I'm personally very enthusiastic about it, and I think it's going to change our landscape. It mimics the conversations that many of us have had with our patients for the last decades. Why do you recommend that this patient have a coronary bypass operation, a very invasive procedure, is to live longer and live better. And if we can more directly measure those outcomes and use that as the metric for judging the effectiveness of what we do, that seems to be more patient-related and appropriate. Our next session, and unfortunately we're going to have to skip over any Q&A, our next session begins now.